Welcome back to another session on neurology. Probably this is going to be the last session if possible. So otherwise we'll extend a little bit, not an issue. I think we have been discussing on the peripheral neuropathies and the muscle disorders. So now we'll be moving on to the brain again. So where we need to discuss on the Parkinson, and we have some seizures and dementia still left where we want to discuss. Before that, I would like to tell on the dermatomes and the myotomes, especially the important dermatomes and the myotomes, which are really, really important. So to start with, we have some myotomes that you need to know for exams, because these are some questions that are quite common in exam. So what are the myotomes? So I'm going to start with, and you're going to tell what are the myotomes. So what about the C1 and C2? C1 and C2 myotome. So I mean, grossly, this is how you check in real practice also, and that's what the exam questions are also going to be. So what the C1, C2 is going to do? I think I'm audible, and at the same time, I think you can see me as well. Hello, can you hear me? Yes. Okay, fine. So C1 and C2 is basically going to be for the neck. So we're going to have neck flexion and neck extension. So this kind of movement. So this is neck flexion extension. This is C1 and C2, concerned with C1 and C2. And C3 is more of a lateral extension of the neck or lateral flexion of the neck. This is an S movement and this is a no movement, right? So lateral flexion. Lateral flexion of neck is C1, C2 and C3. As far as the C4 is concerned, it's more of shoulder elevation. Concerned with the shoulder elevation. And the C5 is the most important dermatome of all, considering the importance in exams. That's really important. That is going to be for shoulder abduction. Shoulder abduction. So shoulder elevation, C4, and shoulder abduction is C5. So as far as the exam is concerned, this is going to be the most important, C4, C5. And then we have the C6. C6 is more of an elbow flexion and wrist extension. That is C6. As far as C7 is concerned, you'll be having elbow extension, then wrist flexion and finger extension. So there is a trick to remember this C7, to be honest. So C7 is another important one. So if you know this, it's easy to understand. So what is the trick to understand the C7? It's quite simple. So where you're going to form 7 with your hands. I don't know, I don't have the space to do here, but this is how you make a 7, isn't it? So if you see, this is how it's going to be 7. So to make a 7, what all you do? You do a elbow extension, and wrist has to be flexed and fingers has to be extended. So that's how we make a 7. So that's C7. So it's easy to understand. Elbow extension, wrist flexion, and finger extension. And as far as C8 is concerned, this is very, very important again. So this is for finger extension, finger flexion. In fact, the finger flexion reflex is also based on the C8 only, which means C8 is another very important one. Then we have T1 finally. T1 is for finger abduction and adduction. You would have studied dab and pad based on the lumbricals, isn't it? Dorsal and palmar lumbricals, dab, pad, abduction, adduction. So that's concerned with the fingers. So finger abduction and finger adduction is T1. So these are the upper limb myotomes, to be precise, and very important for exams. The T1 is also seriously important for exams as far as the myotomes are concerned. So C1, C2, C3, C4, C5, C6, C7, C8, T1. In that C5, C8 and T1. So these are the 3 root values very consistently asked in exams, because those are the areas which will be commonly going for entrapment in the setting of a radiculopathy. And one more interesting feature is they will be asking about the intrinsic muscles of the hand. I'm telling only the high yield points. I'm not telling how to check all these things. That's probably coming up in 2.0. But you have some certain intrinsic muscles of the hand. These are small muscles of the hand. You know, within the hand you have some intrinsic muscles. As far as the intrinsic muscles of the hand, this one important thing that is very commonly asked in exam is almost all the intrinsic muscles of the hand are supplied by T1 nerve root. So whenever you take a radiculopathy and if you have wasting of the intrinsic muscles of the hand, which means T1 is affected for sure in a radiculopathy. So all the muscles, every single muscle, every single intrinsic muscle of the hand is basically supplied by T1 only. Similarly, all the intrinsic muscles are supplied by ulnar nerve. By ulnar nerve, with the exception of 4 muscles. With the exception of 4 muscles, these are called as loaf group of muscles. That's a mnemonic for that loaf, except the loaf muscles. L stands for lateral lumbricals. I can put a different color, I guess. L stands for lateral lumbricals. And O stands for opponents pollicis. And A stands for abductor pollicis brevis. Remember, abductor pollicis longus cannot come here because longus is a long muscle. Brevis is a small muscle of the hand. So abductor pollicis brevis. And I think spelling again I'm writing wrongly. Abductor pollicis brevis. And you have the flexor pollicis brevis. Flexor pollicis brevis. Right. So these are the 4 muscles. You have lateral lumbricals, opponents, abductor pollicis brevis, and flexor pollicis brevis, except these 4 muscles called as loaf muscles. Remaining all the muscles are basically supplied by the ulnar nerve. And all the muscles of the small muscles of the hand, intrinsic muscles of the hand are basically supplied by the T1 nerve root only. So these are the 2 other important points that is very, very commonly asked in exam, which means this loaf group of muscles are supplied by which nerve? We know that that's a median nerve. Except loaf, everything is supplied by ulnar nerve only, but this loaf group of muscles are basically supplied by the median nerve. That's all. This, I mean, if you know this much for exams, this must be more than enough as far as the myotomes are concerned. And then we have the lower limb myotomes. What are the lower limb myotomes? For example, L1, L2 is there. Like how C1 and C2 is important for neck flexion, L1 and L2 is important for hip flexion. In this particular setting, then we have L3 and L4, very, very important root value of all, L3 and L4. Compared to everything, this is very commonly asked. This is for knee extension. So imagine that knee jerk is also basically based on L3 and L4 only. Knee jerk reflex is basically an extension sort of a reflex. Then you have L4 alone, which is important for ankle dorsiflexion. Dorsiflexion is moving towards your legs. That is ankle dorsiflexion, right? Then you have L5, very important dermatome again, that is toe extension. Toe extension, especially this is important for the great toe. More important is for the great toe extension. So I can put a box here and I can tell this is very, very, very important because whenever you think about the lumbar spondylosis or any stenosis of the lumbar canal, in that the most commonly affected root is the L5. So in intervertebral disc prolapse in the lumbar zone. So L5 is extremely commonly affected. So that's why that L5 nerve root is really, really important to understand. Great toe extension, very common nerve root damaged in lumbar spondylosis and intervertebral disc prolapse. L5, that is great toe extension. That will be lost in this patients. And you have S1. S1 is for plantar flexion of ankle. So I can write ankle plantar flexion. And remember, S1 is the one that supplies the sole of the foot also. So in a superficial reflex called plantar reflex, S1 is going to be very important. So ankle plantar flexion, as far as S1 is concerned. Then you have S2, that is knee flexion. So S1 is also important for hip extension and knee flexion. Knee flexion, but for knee flexion, more important nerve root is the S2. So whatever I have marked in yellow here are going to be the most important nerve roots for exam. So C5, don't forget shoulder abduction, and C8, it is finger flexion, and T1, it is finger abduction and adduction, and L2, L4 is L3, L4 is knee extension, and L5 is great toe extension, And S1 is ankle plantar flexion, and S2 is going to be knee flexion. And out of all these things, if you want to pick up only 2 or 3 to know for exams, of course, shoulder abduction, then I'll go for finger flexion, and I'll go for probably L5, grade 2 extension. If you want to pick up only 3 among these 3 things, I'll tell these 3 are the most important for exams. Remaining, you can think about, so whether to learn or not, but everything is important, but whatever is marked in green are going to be the most important for exams. And please don't forget that every intrinsic muscle of the hand is supplied by T1, and all the intrinsic muscles are supplied by ulnar nerve except the loaf muscles, which are supplied by the median nerve. And now knowing the root value. For knowing root value, I usually tend to draw something called a inverted reflex man. So, normally you draw like this. Don't draw anything now. So you're going to draw something like this. For example, if you take, this is how a man is. So what I'm going to do is I'm just going to invert and draw something called an inverted reflex man. So where I can put the feet here, then I can put the leg here. Then it couldn't be the thighs. And this is going to be the body. And of course, this is going to be the head. And I can put the hands, then of course the forearm and the fingers. So this is going to be my inverted reflex man. So I've just inverted the image, whatever I've drawn. So this is going to be the sole of the foot. For example, you're just going to write 1, 2, 3, 4, then probably 5, 6, and 7. 5, 6, 7 maybe. You can write 7 also here. Maybe, or we can write 7 here. 5. That's extension, right? 5, 6, 7, and probably 8 at this point. So which means I've just written 1, 2, 3, 4, 5, 6, 7, and 8. So you know that this area, that this is S1 and 2, is for the ankle jerk, ankle reflex. And you have L3 and 4, which is important for knee jerk. And you have C5 and 6, C5 and 6, which is important for the brachioradialis and the biceps reflex. Instead, I will write C5. I mean, even both are involved in both reflexes, but C5 is more of a brachioradialis type of reflex. And C6 is very important for biceps. But remember, both will be given in the textbooks, both C5 and C6. But C5 is more for brachioradialis and C6 is more for biceps, but both roots are for both reflexes. And we have C7, which is for triceps. And we have C8, which is for finger flexion. Finger flexion reflex. C8 is for finger flexion reflex. Clear? So what are the nerves that are taking care of this reflexes basically? And what are the muscles that are taking care? As far as the ankle jerk is concerned, the muscle that is taking care is tibialis posterior. And the nerve that is supplying this particular, apart from the roots, the nerve that is supplying is the posterior tibial nerve. Posterior tibial nerve. That's the one that is supplying the ankle and that particular ankle jerk kind of a muscle. And as far as the knee jerk is concerned, we know the most important group of muscle is the quadriceps. That's going to be the important thing for the knee jerk. And this is supplied by the femoral nerve. And the root value is L3, L4. Then as far as the, biceps reflex is concerned, biceps is basically due to the biceps brachii muscle. And this is supplied by the musculocutaneous nerve. Musculocutaneous nerve is important for the anterior compartment of the arm, and posterior compartment you have triceps, that radial nerve. So anterior compartment of the arm, musculocutaneous nerve is the major blood supply, supply. Then brachioradialis, then we are moving to the triceps. As far as triceps is concerned, C7. So the muscle is the triceps, and it's going to have 3 heads. That's why it's called triceps. And the nerve that is supplying is the radial nerve, of course. In the entire posterior compartment of the arm as well as the forearm, the radial nerve is going to be the most important. As far as the finger flexion is concerned, it's the flexor digitorum profundus and superficialis. Profundus and superficialis are going to be the key. So remember, this is basically supplied by the median nerve once again. Flexor digitorum profundus and superficialis, except the lateral 2 heads of the medial 2 heads of the flexor digitorum superficialis. Remaining everything is basically supplied by the median nerve only. It's one of the important nerve of the flexor compartment of the arm. But except for the medial two heads and medial two tendons of the superficialis, remaining everything is basically supplied by the median nerve only. So the most important nerve here is the median nerve, but with some variations. But of course, the most important will be to understand the root values. That's why I told you this inverted reflex man, S1 and 2 for ankle, L3 and 4 for knee jerk, C5 and 6 for brachioradialis and triceps, and C7 for, C5 and 6 for brachioradialis and biceps, C7 for triceps, and C8 for finger flexion. And you also know what are the nerves and the muscles that are respectively important in the setting of a different group of reflexes. And we have the cremastic reflex. Some superficial reflex are there that is very important. The first one is the cremastic reflex, which is basically in the root value of L1 by the genital branch of the genitofemoral nerve. We know what is cremastic reflex, and don't do cremastic reflex in females, of course. It has to be done in males only. So genital branch of genitofemoral nerve. Genitofemoral nerve. And we have the plantar reflex. Plantar reflex is going to be supplied by root value called S1. I told you as usual, S1 is the dermatome for the sole of the foot. And of course, plantar reflex will be taken by the S1 only. S1 is the root value for plantar reflex. Most important point. And there is one important reflex is that is equal. I forgot to tell this. That is equal to that of the peripheral neuropathy. You can do it as a laboratory basis. That is equivalent to that of eliciting a plantar reflex, or eliciting equal to that of an ankle jerk. So we have studied a lot of investigations here in the nerve conduction study. Where is that? Where is that? Where is that? In the morning. NCS. Yeah, we have studied nerve conduction studies here. But we have not studied about one important thing. That's a very common question asked in exam. That's called a H reflex. So no need to know anything about the H reflex as of now, but H reflex is very important for testing for S1 neuropathy. So you can remember, like, this is an ankle jerk or a plantar reflex equivalent. So I will tell it as an ankle jerk equivalent because ankle jerk's most important root value is S1. S2 is also important, but S1 is the most important root value as far as ankle jerk is concerned. And for checking for S1 neuropathy, H reflex will be useful because it's like doing an ankle jerk only. So whenever you have absence of H reflex in your nerve conduction study, it is like having an S1 neuropathy. Only that point has been asked 2-3 times in the past, so that's why I told you. Please make a note of it. Apart from that, I don't think that's going to make any sense by knowing most things about it. So H reflex again. So it's an equivalent of an ankle jerk. And you have abdominal reflexes also. That's also another superficial reflex. T7 to T11, anywhere you can tell the dermatome, no problem. So that's where you check for the abdominal reflex bilaterally. And more importantly, you need to know one important sign called a beaver sign. Everyone knows what you mean by beaver sign. Whenever you ask the patient to lie down, and when you ask the patient to get up from the bed, the umbilicus will stay in the same position because above the abdomen, below the abdomen, both the muscles are contracting properly. Suppose in the setting of a T9 or T10 neuropathy, because T10 is the most important. You have a T10 neuropathy. You have problems in the T10 level, which is actually at the level of the umbilicus. Now, if you have a T10 neuropathy, means below that, the muscles will be weak. Of course, muscles will be weak at the spinal cord level. But above the T10, the muscles will be normal. So which means because of this imbalance, so what really happens is when the patient tries to get up, the umbilicus moves up. Why the umbilicus moves up? Because lower portion is weak, and because the upper muscles are strong above the umbilicus, they try to pull the umbilicus up. So this pulling of the umbilicus up in a probable T10, T11 neuropathy, but in exam, you have to answer T10 only, in a probable T10 neuropathy, or not T10 neuropathy, at the T10 spinal cord level. T10 myelopathy. So in a T10 spinal cord injury, when the patient is asked to get up from the bed, this relative movement of umbilicus in the upward direction towards the head is what we refer to as something called a Beaver sign. That's very important. That's a sign of a T10 spinal cord injury. That's why that point is very important. But it can happen sometimes at T11 also. But in exam, please always answer T10 because T10 is what it supplies the level of the umbilicus. And as abdominal reflex is concerned, T7 to T11 is going to be the root value for this abdominal reflex. And what is the importance of this abdominal reflex? Only one importance is there. Remember, abdominal reflex is lost in all human lesion. Any human lesion, all human lesions, abdominal reflex will be lost. Only one exception for this rule is there. What is that exception? That is ALS, amyotrophic lateral sclerosis. In amyotrophic lateral sclerosis, you will have a human as well as an element lesion. So if they ask you if there is one exception for a human lesion with a preserved abdominal reflex, then in that setting, you should answer amyotrophic lateral sclerosis. Remaining all the other humans, basically, your abdominal reflex will be lost. That's the most important point there. So I think we have discussed enough on the important aspects of myotomes. Then we have discussed on the reflexes. Then we have reflex on superficial reflexes. In that, and Beaver sign is also very important for exams, which is happening at the level of T10 spinal cord injury, the movement of the umbilicus up. And finally, we have ALS, where abdominal reflexes will be preserved. That point is important. Apart from that, every other humans will have a lost abdominal reflex only. Then we have some, dermatomes also. Certain dermatomes are very important for exams to be known. So what are going to be those dermatomes? So we have upper limb dermatomes and lower limb dermatomes. Let me write separately. These are the dermatomes because these are the areas where you need to check basically. In the upper limb, you have C2 dermatome. C2 usually tested the external occipital protuberance basically. I'll write as EOP because I don't want to write fully. You can write fully. External occipital protuberance here. And at the same time, the same dermatome will be covering up the angle of the mandible also here. So angle of mandible, you're going to test for C2. And why this point specifically I told that angle of mandible is supplied by C2. That is because many times it's confused the trigeminal nerve area. Remember trigeminal nerve, in that you have ophthalmic nerve. The best area to test for phi1 ophthalmic nerve is immediately above the eyebrow. In the middle of the eyebrow, immediately above that, if you check, that's the best area to check for the ophthalmic nerve, phi1 division, because that's surely ophthalmic nerve only. And as far as the maxillary nerve is concerned, the best area to check for the maxillary nerve is above the angle of the mandible or probably near the, near the zygomatic process. So this is the place where you can check for the maxillary nerve. And if you want to know for the mandibular nerve, the best area to check is below the angle of the mandible, maybe at this point. Clear? In the, just above the mentum near the jaw, below the angle of the mandible. So this is the best place to check for the mandibular nerve. But this area, if you think that this area is, okay, this is mandibular nerve, but if you go later and later, in this particular zone, it will become C2, greater auricular nerve. So because it's supplied by C2, if you test at this point, you're actually not checking the trigeminal nerve, you're actually checking the C2 dermatome. So that's why avoid checking on the, like angle of the mandible. Don't do that. So test in appropriate places. That's why I told you that point angle of mandible is going to be really important. And then you have a C3 dermatome. C3 typically is in the supraclavicular fossa. Supraclavicular fossa, that's where you're going to check for C3. And we have C4, where you're going to check in the acromioclavicular joint, AC joint, acromioclavicular joint, and C5 is really important, where you'll check in the lateral antecubital fossa. Lateral antecubital fossa at this point here, lateral antecubital fossa. That's where you will check. And the C6, here comes the most important thing. C6 is thumb and the C7 is middle finger. C7 is middle finger and C8 is little finger. C8 is little finger and T1 is the medial antecubital fossa. Medial part of antecubital fossa. It's easy to understand. It goes like a U from here to here. It comes like a U, isn't it? So lateral antecubital fossa, then thumb, middle finger, little finger, then medial antegular fossa. It comes like a U. So all from C5 to T1, it becomes really easy to understand. In that, usual questions in exams will be C6, C7, and C8. In that, C8 has been asked multiple times in the exam. I don't know why. C8 has been asked so many times. Little finger. And T2 is axilla. That's really simple. And T4 is going to be at the level of the nipples. Nipples is T4. And at the level of umbilicus, I told you it's T10. T10 umbilicus, T4 nipples, and T2 is axilla. These are very common landmarks. But coming to the lower limb, lower part of the body, you have L1. L1 is basically in the upper lateral anterior thigh, or I can write anterolateral part of the thigh in the upper aspect. As far as L2 is concerned, it's the mid anterior thigh, and L3 in the lateral femoral condyle. Lateral femoral condyle. That's the best place. L4 is medial malleolus. L4 is medial malleolus. L5 is in the dorsum of foot, especially first and the third metatarsophalangeal joints. That's the best place to check for L5. Then you have S1. S1, I told you the entire heel is supplied by S1 only. So in the plantar aspect of the foot, S1, that is the best place to check for. And we have S2, popliteal fossa. We know where the popliteal fossa is. That's why I check for S2 and S3. You sit now on that. That is ischial tuberosity. Everyone sits on the ischial tuberosity only. And S4 and S5 will be on the perianal skin. But in this, among all this, I'll feel the most important will be the L5 and the S1. So these two are going to be the most important. L5 and S1. Clear? Because dorsum, L5 is very common root that is trapped in intervertebral disc. That's why I told you L5 is important. Dorsum of the first and the third metatarsophalangeal joint. At least you can remember on the dorsum of the foot at least. And the heel is supplied by S1. Okay, I think you must be able to get this, right? Understood or not? These are the values, and I cannot have any mnemonics for that. If you know any mnemonics, you can tell. Whatever mnemonics I had, I told you. Understood or not? So we can move on to the next one. Clear? Yes. So I think I've told whatever tricks I know, whatever tips I know, I've told you, and what are the important things is there, I mentioned. S4 and S5, you're asking Abhiram, it's perianal skin around the anus. That's where S4 is. So we have discussed on all the myotomes and the dermatomes, which are important for exams. Then we have the dementias, right? We have the dementias. So currently we don't really call them as dementias to start with. Currently the name has been different. That's called neurocognitive disorders. So first of all, let us start with what do you mean by a neurocognitive disorder and what are the cause of confusion in clinical practice? What are the things that cause confusion in our setting? First of all, confusional states. And anything can cause confusion and delirium. Like for example, it can be even due to a like infection elsewhere in the body. Like even urinary tract infection can result in the development of confusion. So we don't want that. So I'm going to talk about the intracranial cause of confusion. But the first is vascular cause. Vascular causes can produce confusion. What are the vascular causes that can cause confusion? Of course, the first thing that comes into my mind is stroke and TIA. Very, very common cause of confusion in the like anywhere in the world. Then we have hemorrhage, subarachnoid hemorrhage can produce confusion. And if you want to know the features of stroke and TA, phonological deficit, of course. And as far as the subarachnoid hemorrhage is concerned, I'll be thinking about more of that acute severe headache, thunderclap headache, worst headache of the life, neck stiffness. That's going to be the most important key feature that tells you it's a subarachnoid hemorrhage. Then on top of that, we have meningitis, which is due to infection. I know that. So that's the reason for development of meningitis. And what will be the features that favor meningitis? You know, fever, neck stiffness, or neck rigidity, and altered sensorium. So this is a classic feature of meningitis. Apart from that, you might have a photophobia, vomiting, that is projectile vomiting, can be there. But these are very classic, may not be seen commonly in clinical practice. Then you have encephalitis, which can produce similar kind of a picture. But remember, encephalitis patients will have additional, same problem, plus additional focal deficit can be there in encephalitis. Because here the brain is getting inflamed. Meningitis or encephalitis, both meningitis and encephalitis, only thing that separates encephalitis from meningitis is the addition of vocalogical signs, and the patient may have some cognitive deficits. That's the only thing that separates encephalitis from meningitis clinically. If brain substance involved, that's encephalitis. If only meninges are involved, that is meningitis only. Then we have abscess formation, brain abscess. Of course, even in abscess, they will be having vocalogical deficit. That's the key feature. And along with it, they will have high fever and all this stuff. Then, okay, abscess is there. Then we have some autoimmune causes also. Autoimmune cause in the sense we have vasculitis. Vasculitis typically tend to come with some inflammatory signs. For example, they will have arthritis. They will have skin rashes. And of course, they will have an extremely raised CRP and ESR. And multi-organ involvement is a classical feature of vasculitis. Usually, it will not come only with CNS involvement. Generally, they will have multi-organ involvement to start with. And you can get with paraneoplastic syndromes. We'll discuss more about that. What about paraneoplastic syndrome? Usually, there will be features of underlying malignancy. But most commonly, they will produce something called a limbic encephalitis. Limbic encephalitis. And they will produce something called a cerebellar symptoms, cerebellar ataxia. This will be the usual feature of paraneoplastic syndrome, and usual clue will be underlying malignancy. There will be some malignancy in the patient. A malignant patient coming with confusion, but you don't have any vocalogical deficit, then you can think about paraneoplastic syndromes. We'll be discussing about that in detail later on. But if they have vocalogical deficit, then it must be due to usually metastasis. So usually in non-metastatic, this paraneoplastic syndromes causing confusion. Malignancy will result in no vocalogical deficit. And that's how they give an exam for you to help you to differentiate these two stuff. And you have anti-NMD receptor antibodies. Many things are there, which we'll be discussing after some time. Then it could be neoplastic cause in the brain. Neoplastic cause, typically they come with the raised ICP features, vocalogical deficits. Many tumors are there. We're going to discuss later on. So many tumors are there. It could be a traumatic entity. Trauma, EDH, SDH, like even subarachnoid hemorrhage can come as a result of trauma. Then seizures. Another important neurological cause, especially status epilepticus. So we know what seizures are, and I don't want to give any clue for that. Or it could be psychologic. Very rarely it could be psychiatric. The biggest clue in psychiatric is patients will not have any organic symptoms and signs. In the sense, how much ever you examine, how much ever you check for it, you will not get any organic symptoms and signs, which means all the imaging investigations, whatever you do, will be usually normal in a pure psychiatric illness, which means it's a functional disorder. There is no underlying organic problem. So some, causes of a confusional state. We are talking about only the neurological cause of confusional state. I will just told you what are the clues to find out what is the cause of confusion. All these entities in exams, they can come with confusion. So you have to separate based on the clinical features that you are seeing. Doesn't matter. Okay. Then we have to move to the neurocognitive disorders. So currently we don't call it as dementia. We call it as a major cognitive impairment. So we call it as NCD, that is neurocognitive disorders. As far as the neurocognitive disorders are concerned, you have mild neurocognitive disorders and major neurocognitive disorders. Major neurocognitive disorders. Previously, these major neurocognitive disorders are the ones that have been called as dementia. Currently, the term dementia has been completely removed from our textbooks. Only you have mild versus major neurocognitive disorders. So how to differentiate between a mild and a major neurocognitive disorders? In mild neurocognitive disorders, the day-to-day life activities, we call it as ADL, activities of daily living, and we have something called IADL, that is called indices of activities of daily living, or indicators of activities of daily living, like brushing, walking, doing their day-to-day activities like going to bathroom, motion, bathing, dressing, taking care of themselves. This is what we call as activities of daily living, will be unaffected. Whereas in major neurocognitive disorders, these will be defective. They cannot do their like activities among themselves. So you need somebody's help, or they will be doing, but still they'll be doing in a error-prone way. This is what we refer to as a major neurocognitive disorder. But remember, for example, take an Alzheimer's disease. Alzheimer's disease can come with a mild or major neurocognitive disorder, doesn't matter. To start with, they will be having mild neurocognitive dysfunction only. Later on, once the disease becomes severe, they'll become a major neurocognitive disorder. So it's not like Alzheimer's means it should be only major. It can start as a mild, then they'll go for a major. So that is why the term dementia has been removed currently. Even though major neurocognitive disorders are the ones that should be called as dementia, we have completely removed the term, dementia now, and we are replaced with mild and major neurocognitive disorders. In both these settings, the most important problem, the why you call it as a neurocognitive disorder in the first place, because there is some element of cognitive dysfunction. So cognitive dysfunction means there are a lot of domains within the cognitive dysfunction. So cognition is a very higher level activity. So you have so much of, like cognitive functions are there. Like for example, memory is a function of cognition, and memory is the most common cognitive domain that is affected in all these neurocognitive disorders. Even calculation is a cognitive domain. Executive functions, I told you, this apraxia. Apraxia is a problem of executive function, but executive functions, for example, if you want to execute something, I want to take this and drink, I want to write. So all these are executive functions. So I want to execute something in my life. So executive functions will be lost. Memory will be impaired, or patients may not be able to do their day-to-day activities. All these are cognitive dysfunction. So any cognitive dysfunction, if it's there, will be called as a neurocognitive disorder. Despite having a cognitive dysfunction, if they're able to do their day-to-day life in a good way, it's unaffected, then it will be mild neurocognitive disorder. If they are not able to do, then it will be a major neurocognitive disorder. That's all. As far as the major neurocognitive, if you want to know the domains, so what you are going to test. So remember this kind of neurocognitive disorders. Hereafter I'm not going to call it as dementia. Hereafter I'm going to call only as neurocognitive disorders. As far as the neurocognitive disorders are concerned, the domains that we are going to see is going to tell you the difference, and it's also going to tell you the diagnosis. There are a lot of domains are there. So based on the domains, I can write single domain neurocognitive disorder or multiple domains. But the characteristic feature of a disorder like Alzheimer's disease is having a problem in the multiple domains. So what are the domains basically? What all we want to test? So first is the memory. Remember, memory is the most common domain which is affected in any neurocognitive disorder. But see, memory dysfunction, many students think like memory loss is dementia. No, dementia is a cognitive dysfunction. That's why we change the name. So neurocognitive disorder. Neurocognitive disorder means it's a cognitive dysfunction that you're talking about. Memory is just a part of cognition. But most commonly affected is memory, that's all. Amnesia is a very common entity. So memory is affected means we call it as amnesia. And patients may have problem in visuospatial deficits, visuospatial skills like dressing, doing something. So visuospatial skills may be lost completely. May have a visual agnosia. So visuospatial skills is a second domain that we need to know. Then we have this attention span. You are listening to me. I don't know whether you're listening to me, but some people, at least now currently 63 participants are basically attending to me at this point of time. So attention. So it's a very important cognitive function. Then as I told you, a lot of executive functions are there, which are important for day-to-day life. Like even taking a water bottle and drinking also needs some execution to be done. So these are some of the examples. For example, you can have amnesia, apraxia, agnosia, acalculia, then aphasia, speech and language. We didn't talk about that. Speech language. So this is another domain of cognition. So like this, yes, we can write 15, 20 domains are there, but these are the most important domains that we are really going to check for. And how to check for cognitive dysfunction? We have different scales to check for cognitive dysfunction. But of course, we have the MMSE scale and we have the MoCA scale. MMSE, we know what is MMSE. It is mini mental status examination. Score ranges from 0 to 30. But remember, MMSE is less sensitive, which means it's not able to predict. I mean, it cannot find out the mild neurocognitive disorders. For major neurocognitive dysfunction, it's sensitive. But for picking out this mild neurocognitive dysfunctions, MMSE is not that sensitive. When you call it as severe dementia, whenever MMSE score is less than 12, we call it as a severe dementia. That's the only definition. But mild to moderate dementia, the cutoffs are variable and it's not very proper. And again, these tools heavily depend on the literacy rate because they need something to be done, like drawing, writing, and all. So they completely depend on literacy rate also, because if the patient is not illiterate, then it's very difficult to predict what is the category of dementia or neurocognitive disorder. To tell that the patient is having a particular degree of neurocognitive disorder, the patient should have a decent amount of education. And we have made some attempt to standardize these values based on the education, but it becomes too complicated once again. That's the problem. Right now, we don't have a very simple tool to find out this neurocognitive disorder. It's always complex and complicated. Fine, MoCA is in the sense like more convenient because it's having more sensitive, but it's more complicated as well. But it's quite sensitive compared to MMSE. MMSE stands for Mini Mental Status Examination. MoCA stands for Montreal Cognitive Assessment. Montreal, M-O-N-T-R-E-L. Montreal Cognitive Assessment. But MMSE, I mean MoCA, has more sensitivity compared to the MMSE scale. And the problem is, even when I teach this dementia for PGs, like the neurocognitive dysfunction for PGs, they will feel it difficult because they feel that this is not their domain, especially when an undergrad is being learned with a neurocognitive disorder or a dementia. They feel it's even more tougher because it's really like tough, because they have not seen a case of dementia till now, and they are not going to see as well, because all an undergrad wants is a stroke, and probably if they remember a little bit of meningitis, and that's enough. So feel that's all, neurology is over for them. But one of the common things that we encounter in clinical practice is this neurocognitive disorders. So it's very important as far as my practice is concerned. And you can teach about neurocognitive disorders alone for 6-7 hours really. So much is there on NCDs. But the idea is like, I need to wind up quickly as what are the important things about exams and what are the updates that we have right now, and what are the most important points, so that in exams, if you see that particular point, you can go for one particular diagnosis. So diagnosis is more important, because even though these disorders doesn't have much treatment, diagnosis is the key. That's what is going to be the questions in exams. So now I think you will be knowing what do you mean by cognitive dysfunction, what are the domains to be checking in cognitive dysfunction, and based on domains, it's a single domain problem or a multiple domain problem. And then we can also talk about whether it's a mild or a major neurocognitive disorder. Major neurocognitive disorders are the ones previously that are called as dementias. Now the name has been changed. And what is the difference between mild versus a major neurocognitive disorder? And you need any investigations to find out neurocognitive disorder. Actually, to be honest, it's a clinical diagnosis, neurocognitive dysfunction. You cannot rely on investigations unless and until there is some secondary cause of dementia. So why you do investigations? This is to rule out secondary causes of NCD. Secondary cause of NCD. And whenever you talk about the secondary cause of NCD, there are some reversible causes of neurocognitive dysfunction, or we can call it as reversible cause of dementia previously. There are many causes out there, but usually I used to give by a mnemonic called SINBIN. So that's the mnemonic I generally tend to give. S stands for STH, subdural hemorrhage. I stands for some infection, IFX, which means infection here. With one exception, that's prion disease, that is Creutzfeldt-Jakob disease, which is irreversible basically. Apart from that, majority of the infections are reversible, and N stands for certain neoplasm in the brain. B stands for B12 deficiency, which can cause dementia, neurocognitive dysfunction. And I stands for insufficient thyroxine, the sense like we're talking about a myxedema or hypothyroidism. And N stands for normal pressure hydrocephalus, NPH. Very important, because V patient sometimes can reverse the NPH related dementia. So reversible in the sense I'm talking about a sometimes reversible. It's not all the times, sometimes reversible causes. In the top of the list is subdural hemorrhage, very, very commonly asked. I told you, especially chronic stage happening in elderly may present like a dementia. And second one is the B12 deficiency. That's very important for exams. Myxedema, very important for exams, and NPH is also very important for exams. These are the usual things that can be almost near completely reversed, except NPH. NPH, sometimes it may not be completely reversed, but many other things what I have discussed are completely reversible if you treat them early and proper on time. So what are the investigations that you can do? Basically, there are many investigations are there. For example, you can do a CT or an MRI. It's the most common investigation that is done for any neurocognitive dysfunction, because NPH, okay, 11 is asking what is NPH? NPH is normal pressure hydrocephalus. Normal pressure hydrocephalus. That is NPH. So CT and MRI is the most common investigation that is done for the purpose of finding out the secondary cause. So in the sense, like, it can find out SDH, it can find out tumors, it can find out NPH, sometimes even cortical venous thrombosis could be picked up. So many things you can pick up in CT and MRI. But if it's a primary cause, most common finding, most commonly done investigation, most common finding that you get in a CT and MRI is brain atrophy, cortical atrophy. Atrophy will be seen at some areas. This is the most common finding is seen in many primary type of neurocognitive disorders. But this doesn't give you any clue at all. So cortical atrophy can happen in the setting of elderly, or cortical atrophy can happen in the setting of Alzheimer's disease. You cannot really predict based on that. And there are some newer investigations like you can do SPECT imaging, and you can do functional imaging like with the PET scan with certain traces, which I'll be discussing. Then you can do CSF analysis, where CSF analysis is important. Anyway, we'll be discussing about that. CSF is important for diagnosing Creutzfeldt-Jakob disease sometimes, because you see a protein called 1433. There is no name for that. That protein is called 1433, which can be picked up in the CSF, or A-beta amyloid in Alzheimer's disease can also be picked up in CSF. So it all depends. Fine. So this is a simple overview of neurocognitive disorders. So the terms are very important. And further, neurocognitive disorders can be divided into based on which lobe is primarily affected. So for example, most common area that is affected, which means most common lobar zones that will be affected in neurocognitive dysfunction is frontotemporal NCD. So they'll be put under something called a frontotemporal NCD, because most of the neurocognitive disorders, see, I'm not talking about a frontotemporal dementia, I'm talking about a frontotemporal neurocognitive disorder. Most of the neurocognitive disorders will be affecting this frontotemporal region only. They'll not be affecting other areas. Okay. So what are the types of dementia previously we know? So we know Alzheimer's disease. So Alzheimer's disease is one thing I can write in both major as well as minor neurocognitive disorder. Apart from that, majority of the other disorders tend to be major neurocognitive disorders only. For example, we have an FTD that's called a frontotemporal dementia. As I told you, new name for FTD is frontotemporal neurocognitive disorder. And in fact, there will be considerable overlap. Most of the NCDs also will affect the frontal lobe and the temporal lobe only. Then we have a vascular dementia that's called a vascular neurocognitive disorder now. You can write vascular NCD, vascular neurocognitive disorder. Then we have dementia due to Lewy bodies, or I can tell currently, because the name has been changed to NCD, I can write NCD with Lewy bodies, neurocognitive disorder with Lewy bodies. Then we have other conditions like Parkinson-related neurocognitive disorder, HIV, NCD. So many other causes are also there. But these are the things that we are going to see in detail. Alzheimer's disease, then frontotemporal dementia or frontotemporal neurocognitive disorder. Then we have vascular neurocognitive disorder. Then neurocognitive disorder with Lewy bodies, previously called as dementia with Lewy bodies. Fine. I think this must be enough. And they will be asking you, there are something called geriatric genes. What do you mean by geriatric genes? Because history of this is very, very important whenever you ask a history for neurocognitive disorder. Geriatric genes means if these are there is a strong possibility of having an underlying neurocognitive disorder. That's why these are called as geriatric genes, which happen in the elderly population. Number one is confusion, incontinence, and falls. Incontinence and falls, recurrent falls in elderly, confusion in elderly, incontinence. So this is the first geriatric giant. And second is memory, forgetfulness, and at the same time, safety. In the sense, like many people might wander around forgetting to lock the door. I mean, this is something very common, isn't it, in elderly people? And that indicates a mild or a major neurocognitive disorder. But at the younger, I mean, see, one of the important things is locking the door and going, switching off the gas when you go out of the home. So these are very common safety measures. So if they are forgetting to do this kind of basic safety measures, so then there's a strong possibility of having a underlying dementia. Then behavioral changes, like for example, a person who's going to be nice becomes a little tricky, and a person who's used to be little tricky becomes extraordinarily nice. So behavioral changes, mood changes, anxiety, psychosis, depression, suicidal ideation, personality changes, not wearing the zip. So a lot of behavioral changes are there. If you have some behavioral changes, you can write, then that could be one of the key features for dementia. Then finally, you have to check for the drugs that the patient are taking, because there are some drugs which can cause delirium. So remember, the drugs that cause delirium can be put under something called a delirium index of a particular drug, is directly proportional to the anticholinergic activity, which means any drug that has anticholinergic activity can produce a substantial amount of delirium in the population, especially in the elderly people. That is why atropine is on the top of the list, 100%. Index is 1. Delirium index and anticholinergic activity is 1, because atropine is the criterion standard for anticholinergic drug. That's why whenever you get atropine, the patient goes for delirium. Everyone would have experience. Anyone who's working as an intern or a post-intern right now should be knowing atropine delirium. When you give atropine, the patient goes for delirium. There is a famous line, isn't it, in pharmacology textbooks you will be studying. As red as a beet, as mad as a hatter. Have you heard of that particular phrase? As red as a beet means when you give atropine, they go for flushing. They become very red. And as mad as a hatter means, you know, Mad Hatter, the cartoon character. So you become as mad as a hatter. So that's atropine delirium. So atropine is the top. So any drug that has anticholinergic activity can produce delirium. Yes, as blind as a bat. That is because of the pupillary dilatation. As blind as a bat, as red as a beet, and as dry as a bone, and as mad as a hatter. Perfect. So delirium index is directly proportional to anticholinergic activity. See, any drug that has anticholinergic activity. The usual drug that you miss is the TCAs, tricyclic antidepressants. So these are the drugs that usually you miss in the prescription, because TCAs has a high level of anticholinergic activity, which can produce. And there could be some anticholinergics hidden in the prescription. Like for example, the patient might be taking amantadine. Sorry, not amantadine, triaxiphenidil. Triaxiphenidil is a very common prescription, Pacitane, that is used to treat tremors in Parkinson. So a lot of drugs are there which can produce anticholinergic activity, and they can cause delirium in the patient. And apart from this, a lot of antipsychotics can produce, other antidepressants can do this. So you have to ask a very careful history, and antidepressants, and not antidepressant drugs, antidepressants, and sedative hypnotics, sedatives, hypnotic drugs like benzodiazepines. So you have to ask all this history. These are the most important drugs that we are going to look for. So these are what we refer to as geriatric giants: confusion, incontinence, falls, memory, safety, behavioral problems, and history of drug intake. So these are the 4 important geriatric giants that we have to look for in any history, in any patient who's coming with a probable neurocognitive dysfunction. Apart from that, investigations wise, so many things are there, but that's really not important for us right now. I told you the most important investigations. And CBC also is very important, isn't it? So apart from that, your common complete blood count itself is very important, because it can pick up certain things like B12 deficiency. Thyroid function test is important. B12 folic acid levels is important. So many are there. But nevertheless, it depends on what is your primary degree of suspicion. Then you think about all these things. But till now, whatever I told you, I think it would have made sense, because it's a very, very tough topic, to be honest. And nobody really understands what's happening. But I've tried to explain in the best possible way. What are the terminology changes? What is minor and major, or mild and major neurocognitive disorder? And what are the domains that are affected commonly? And what are the secondary causes of the so-called NCD, dementia? And what are the history, what are the geriatric genes that will tell you that the patient is probably having a neurocognitive dysfunction? Clear. So now it's important to note that the memory is the most important aspect. So we're going to talk about memory now. So whenever you take memory into perspective, what are the types of memory you have? Everyone knows that short-term and long-term memory is there. I'm not going to ask about that, but memory has some process. For example, it starts with something called a sensory memory. So that's where it starts with. And let us see an example in this. What do you mean by sensory memory? And what to ask with regards to sensory memory? Like now I'm going to write something and I'm going to rub it off. What I have written, what number I have written, and I rubbed off. Okay, cool. Everyone is answering that it is 4. This is the best example of a sensory memory. But can you tell beforehand, if you see the previous entity here, first I've written something here. I've written one thing here instead of index, then I've rubbed it off, then I've written delirium index. What is the thing that I've rubbed? Before writing that index, I've written something and I've rubbed off, and I've written index and I've circled it. So what's that I've written there? No, it's not about the drugs causing delirium. I've written separately here. So psychiatry. So it's a delirium index. So it's very difficult, isn't it? You can't really predict. First of all, you don't even know that I have rubbed something there or not. Then what I have written there. So it's not possible to remember. So that is what sensory memory is all about. So you don't understand, right? So come back to that. So sensory memory. Sensory memory has 2 types of memory. One is called as an iconic memory. Second is called as an echoic memory. So iconic memory is something what you see basically. We know that through your vision. And echoic memory is something you hear. That's echoic memory. And this was previously called as something called an immediate memory. So where immediate memory enters is going to be in the cortex and the brainstem. So I can write cortex and processed in the brainstem. So initially enters the brainstem. So which means let us assume a reticular activating formation, that is RAS, that is a central deep part of the brainstem is made of reticular activating system. So RAS is there. So from this point, it enters the cortex. So I can write cortex as here, gray matter. It's going to go into the cortex. So this is what sensory memory is all about. But the problem with that sensory memory is, unless and until you pay sufficient attention to it. So for example, if you do not pay attention, it will be lost completely. In fact, majority of them are lost. It's estimated that exponentially, unless and until you seriously attend on something, almost 99 to 100% chance that they will lose the sensory memory and echoic memory, because you're not paying any attention. Suppose if you are paying a good attention to what is happening, then this sensory memory and echoic memory can enter into a form of memory called a short-term memory, or you can simply call it as a recent memory, or I can write as a short-term memory also. If you pay proper attention, it becomes a short-term memory, or probably a recent form of a memory. So to store this recent memory, your hippocampus becomes really important, which means whatever information that comes to the cortex, there are 2 options. Either they will evaporate, which means you're going to lose if you're not going to pay proper attention. Or if you're going to pay proper attention, then it comes to subcortical areas. For example, you can write a seahorse shaped structure, that is hippocampus. We know that. So it comes to subcortical areas once again, and where it will be stored for some time. So that is a recent memory, or otherwise referred to as a short-term memory. So the main area where short-term memory is stored is basically on the hippocampus. You cannot store short-term memory forever. For example, I can ask all of you, let us take only one. So don't want to take every one of you. Let us take only one. Naveen, let us ask Naveen, what did you have for your breakfast? What do you have for your breakfast? Yes, Naveen answered it is tea and biscuit. I think he's living with the tea and toast diet. Be careful, you can end up with a severe hyponatremia. But nevertheless, so tea and biscuit is what he had, and he's remembering it. Okay, fine, understandable. But I'll ask same Naveen again. Did you go out today somewhere in the morning? Did you go out today somewhere in the morning? Yes or no? Somewhere. Why are you not answering? Yes, he went out. Tell me the exact number of how many people you saw in the road, or probably wherever you went. Only one answer you should give, yes or no. That's all. You know or you don't know. No, I'm talking about the road. When you're going in a busy road, probably how many people you encounter in a day-to-day life. Maybe you're going in a bus, how many people you saw in the bus. Maybe in the bus you are seeing a poster, movie poster, what movie poster, how many movie posters you have seen, how many trees you have seen on the way, how many, maybe probably birds sitting on the trees you have seen on the way. Impossible, right? So of course you cannot tell that. So that's what you think about an iconic memory and echoic memory, or probably an immediate form of a memory or sensory memory. Remember, you need to lose some amount of information, and that is really mandatory. That's needed. And if you're going to remember how many trees you have seen, how many birds you have seen, how many people that have gone on the road at that point of time, a camera might record it, a CPU might record it, but as a human being, you don't want all those things because you believe those informations are completely unnecessary. And that is why this losing of information is also really, really important. Sometimes you might ask me, sir, can we reprogram that, and can we make something like only what I read goes into that kind of a perspective? No, our memory works just like that. So you will lose anyways. If whatever you see 99%, if you don't pay proper attention, it's going to be lost. And that's the basic function, and you have to lose it for your goodness. And some amount of things that you are intended to, and some things which you really involve in it, and some things you are paying a lot of attention to, definitely be stored in the hippocampus, because Naveen told tea and biscuit, that's what he had in the morning. So let me ask you one more question. What breakfast Naveen had on August 22nd? Yeah, August 22nd, what is the breakfast you had? Ashwin is telling same tea. I think Naveen is, it's not Naveen, Ashwin is answering same tea. Maybe if you are having a daily routine, then fine, but Naveen is answering he don't know, probably. Yes, that's correct, because that's why we call it as a short-term memory, because you don't really tend to save it for a long time. Even from the short term, from the subcortical centers, that's the hippocampus, some of the memory will again dissipate. It will be lost. And because you feel it's not important. But there are certain memory which can go back to the cortex, and that will be stored as a long-term memory. To become a long-term memory, you need to store it in the cortex. So at any point of time, it's like a bank. It's like a reserve bank, and you can take the money anytime because it is stored there. So long-term memory. So many students do ask, like how to make a long-term memory of something, but it's very difficult. It's not that easy to make a long-term memory. But to produce a long-term memory, there are a lot of areas where you can proceed. The one way is to associate with emotions, number one. So first thing is to do emotion. So if it's something that is associated with an emotion. So for example, we'll ask Naveen, when did you have diarrhea last? After eating something from outside. When did you have diarrhea last? After eating from outside food? Or maybe vomiting, I'm talking about some food poisoning, not necessarily need to be diarrhea. 2 years ago, what did you have and which hotel you had? What did you have? And which hotel probably? Which food I'm asking? Okay, it was pizza. Where it was got from? Okay. So he clearly know that the pizza is the one that caused the diarrhea. And how he remembered even after 2 years. It's been 2 years, it's such a long time, and still he's remembering that pizza has caused diarrhea and vomiting and food poisoning. Because it's an emotion. Diarrhea is an emotion, isn't it? It's not just illness. And there are a lot of times where we have aversion towards that particular food for a long time because we got severe vomiting and food poisoning. So that's why you need some emotions, basically. So if something is connected with emotions, it's going to become a long-term memory. So that's how you push it towards the long term. For example, you go in the road multiple number of times. Maybe you go in the same direction hundreds of times, but you don't remember whatever is happening on the road. Many people are going, coming, doesn't matter. But there is one accident, very bad accident happening in the road, and you are visualizing blood splashed everywhere, and you know there is something very wrong went on. And even after 10 years, when you are going on later, maybe with your friend or wife or family, you still tend to tell that, like I saw, like accident was very bad and a lot of blood splashed in that area. Like you remember it because that's a kind of an emotion. That's a negative emotion that is associated with that. And either you got scared or it's disgusting, something like that. So that pushed it into a long-term memory. So the one way to push in long-term memory is probably emotions. And second way to push into long-term memory is probably you think about doing the same thing again and again. Repetitions is one way where you can push the long-term memory again and again, and the context of how it is learned. So many things are there where you can push into long-term memory. So which means we are talking about a long-term memory. Long-term memory again is divided into many types. For example, long-term memory can be divided into something called a semantic memory. And first we can call it as an implicit and explicit memory. So I'm going to talk about something called an explicit memory, and here something called a implicit memory. Implicit. Explicit is also referred to as something called a declarative form of memory, and implicit is something a non-declarative form of memory. So how will you know whether it is explicit or implicit? Simple. Something that is explainable is basically an explicit form of memory. Something that cannot be explained is basically an implicit type of a memory. So, for example, if you want to whatever may be the fact to retrieve a particular type of a memory retrieval, there are many areas in the brain. So, but usual way of retrieval of memory, they found out it from the prefrontal cortex. Through the prefrontal cortex only, generally retrieve a memory, which means you have seen some time back, it may be stored in the occipital cortex, but to retrieve that memory, basically you have to first think that you have to retrieve the memory, and that goes towards the prefrontal cortex. And prefrontal cortex is considered to be the gateway for memory retrieval. I'm not telling it is the place where memory is stored. There's a lot of difference. It's the gateway from where the memory is retrieved, which means it's the pass. It's like a license. It's like a toll booth from where the memory is retrieved most of the time. That's why damage to the prefrontal cortex may also have a significant impact on memory. But most of the times it's all about the temporal lobe. That's what you talk about. But the importance of the temporal lobe is limited to the hippocampus, which means whenever hippocampus is damaged, you will not be able to form new memories, because only when you form a short-term memory, you will be pushing towards a long-term memory. Suppose if there is a damage in this area itself, means your short-term memory itself cannot be formed, and there is no point in forming a long-term memory. So whenever short-term memory is affected, there will be an antegrade amnesia. Antegrade amnesia in the sense, whatever things you want to learn new, you cannot learn because you cannot remember, because that's the one that has to store the short term. Then it has to go for the long term. The short term itself cannot be found, means how can you produce a long term memory? So that's where it is. But prefrontal cortex damage or any damage to the occipital cortex, the cortical problems, can slowly result in development of a long-term memory problem. So, and prefrontal cortex is considered to be a gateway for retrieval of memory. So that point is also important to understand. As far as the explicit memory is concerned, I told you anything that you can explain is explicit memory, and anything that you cannot explain is basically implicit memory. So let us see some examples of explicit and implicit memory. The best example for explicit memory is if I ask you what happened in your last birthday, how did you celebrate? You will be able to tell in vivid details, like my friends came, they cut the cake, they gave a birthday bash, and it was a day, and we had like wine or whiskey together, and we went out to, I mean, in colleges it commonly happens, and we went out, we had a truth or dare game where I asked my friend to run with an underwear in front of the ladies hostel. So you tell in vivid details, right? So that's how it is. That's an explicit memory. You know how to explain. It's very easy to explain. That's an explainable thing. Explicit, explainable. So you can tell it. Declarative memory. What about implicit? Implicit is something very difficult to explain. For example, if I ask someone one word like how to drive a car, I mean, you can tell, you can put the key switch on, and you put the gear, put the clutch, but while telling itself, you'll feel it difficult. You cannot really explain. At the same time, when they're driving, you cannot keep telling them, like press this much amount of clutch, turn this much amount of, like your steering or a steer wheel, or at one point you have to turn this much of steering. You cannot give a manual like that. It's all something you understand. Like you have to turn this much. You have to put the steering for that particular turn, for the particular radius, you have to turn in this direction. It's understandable. You know it, but you cannot really tell others. So these kind of memory, for example, best example is going to be a procedural memory for that. So these kind of procedural ways of remembering things is basically a implicit memory. So this is like non-declarative. So you cannot declare it. And number one, as far as explicit memory is concerned, it's more of factual memory. You can again divide into two types. One is called a semantic memory, and second, you have something called an episodic memory. So if you want to know what you mean by semantic memory is memory of certain facts. For example, Taj Mahal is in Agra and it's near Delhi. So these are semantic memories. These are facts basically. And as far as episodic memory is concerned, it's the emotions associated with those facts. So for example, these are the emotions or associations with those facts. For example, if I ask you where is Taj Mahal, you will tell Agra. And at the same time, you really know. So whenever Taj Mahal comes into your mind, something else also comes. For example, you would have went to Taj Mahal with your girlfriend and you only know what you did with her there. So the moment I tell Taj Mahal, you will be knowing that also. So that something happened. So this is a emotion or some association with that particular fact. So that's what we refer to as something called a episodic memory. So you have semantic memory and episodic memory. These are the two forms of declarative memory or explicit memory. Then we have implicit memory. Implicit memory is further divided into three. One is called procedural memory. So I told you sometime back, the best example of implicit is procedural memory. Any procedure that you learn driving, writing. So all these are procedures basically. You know how to do it, and it's very personal thing, and everyone does in a different way. A lot of things, and I mean, you can remember all the other procedures that you do in day-to-day life. If you're married, you will understand all these procedures, how much you should do. You will know it eventually, and it's your personal thing, and you are special in that, of course. Yes. So that is procedural memory. And if there is one thing that has a direct ticket to produce a long-term memory, even not having this kind of sensory memory, short-term memory, nothing like this. If you want to have a direct ticket to have a long-term memory, the only way to produce long-term memory is doing a procedure. Procedural memory has a direct ticket in the sense, like most of the times, not all the time, still you have some sensory component involved. But most of the times it's a direct ticket, direct sort of ticket. You need not go through all this tough pathways retaining. It most of the time enters directly into the long-term memory. So that's the beauty of a procedural memory. That's why we have this clinical practice. When you learn something by doing, you learn forever. If you don't learn something by doing, you tend to forget it. It's a common thing. So procedural memory. Then we have priming. Priming. For example, if I tell the word cell. So I told the word cell. Okay, a lot of people would have thought something. So suddenly I told cell. So how many of you have thought about the cell phone? How many of you have thought about the cell phone basically? How many of you have thought about the cell phone? Ashwin, yes, he has thought about the cell phone. Okay. So 2 have thought about the cell phone. How many of you have thought about the battery that we put here? Battery. Okay. There are 3-4 people who have thought about the battery. Okay. How many of you have thought about the cell, the human, animal cell or plant cell? There's so many people. Why? Because you are medicos. Of course, many people have thought about the cell. Okay, first thought. Okay. How many of you have thought about the jail cell? You have the cell, isn't it, in the jail? Only one. Raman has thought about the jail cell. Okay, maybe he had gone to jail recently. Fine. But Meg has also thought about it. Okay. So, I mean, each and everyone has thought differently about the same word, isn't it? The same cell, but each and everyone has thought differently. So that's characteristic of a priming, which means you have been primed to think about something. Maybe you would have heard about something sometime back. You would have been doing, somebody would have been done in the cell phone. Maybe somebody, because they are attending medicine class very, like sincerely, or they would have seen some physiology or anatomy videos, they are thinking about the human cell or the plant cell. So, like the same word, but many people are thinking differently. So it depends on how their mind is primed to think in a particular way. So this is what we refer to as something called a priming in real sense. So that's very important again. Then we have a third process that is referred to as something called conditioning. So many people think that priming and conditioning are both are same and they're not different, but it's a little different. So it's like you are conditioned to think. Priming is something it's going to change from time to time. So if you're seeing a cell phone, suddenly somebody tells cell, you will always think about a cell phone. So it's going to change, but conditioning is not like that. So the same stimulus will result in same kind of response. You can go and check for the conditioned reflex by Pavlov. So conditioning is something different. For example, each and everything is being located at certain areas. For example, procedural memory is basically tend to be present. The programs are located probably in the basal ganglia and probably in the cerebellum. So this is where the procedural memory is located. And as far as the priming is concerned, it's located in the cortex, cortical locations. And as far as this conditioning is located, it is probably located in the amygdala, in the limbic system. We don't know that. Cortex means you're talking about the neocortex, the upper surface of the cortex. So that's what you're talking about. And as far as the semantic memory is concerned, semantic memory is probably located in the association areas. That's where semantic memory is thought to be located. And as far as the episodic memory is concerned, it's probably again located in the neocortex only. This is where we think that episodic memory is located. So we have many, like steps, isn't it? So you have a sensory memory initially, otherwise referred to as immediate memory. Then we have short-term memory, with the hippocampus is going to be the most important. For long-term memory, I can tell neocortex is the most important location. I mean, as a whole, neocortex is the most important location, but still you have many areas for many functions. So this image is also very important. Initially, it goes from the reticular activating system towards the cortex, from the cortex into the hippocampus, from the hippocampus back into the cortex to call it as memory. So short-term memory is what we sometimes call it as a working memory, and that kind of like terminologies need not be used nowadays. So it's just like a short-term memory. That's all. That's basically sometimes referred to as something called a working memory also. All right. So we have 3 groups of memory: sensory, short-term, and long-term. Viva examiner asked a question, I don't remember, but then he gave a hint. I remember it. What kind of memory? So that's again a kind of a priming, because you are able to remember based on a hint, which means you remember it already. So it's a kind of a long-term, but because of that hint, you are able to remember because you are associating it. So that is a type of a priming only. So you are primed to, get something out of you. So that's a priming. Okay. Anything else? No, that is not conditioning. Conditioning is different. Conditioning is like a kind of a conditioned response, a fixed response. Priming is like a variable response. I think you will get what I'm trying to tell. For example, a dog, you know, the Pavlov's experiment. Every time the bell rings, the dog salivates. You don't do that. Yes, bell for food. That's kind of a conditioned response. The same, you know, like same response for the stimulus every time. But the same response later on, maybe giving rise to a different thing. That's priming basically. So the clues and all what you tell, the same clue can be applicable for anything. For example, I will tell a simple example for that. What is priming? That's a good example actually. In my second year exam, I had a senior. I don't want to tell his name. I have a senior who's been writing exam for a long time. He's been writing first year for 3-4 times, and second year he wrote some 2-3 times, and he was attending with us. He's my actually a great senior. Like after my next batch, the next batch senior, he's attending pharmacology exam with me. That time a professor came and he asked what is the treatment, you know, like for rickettsial infections. That's what he asked. And I mean, he didn't know basically. And my another professor was there. He's the intern examiner. So he was telling this. Like this. He was giving a clue. This is a clue basically. If it's a conditioned response, you should have told immediately. It's not a conditioned response. So he told like this. So when something like this he told, we all know what this means. So he told tetracycline. Tetra means 4. So that's a clue there. So tetracyclines, doxycycline, something. We thought that's what he will tell. But you don't believe he told anacin. Because that time there was a favorite ad called anacin will be there. That 4 things will be cured with anacin, headache, fever, and all these things. So he told anacin, and examiners got shocked actually. So you think this clue is kind of a conditioning or a priming? I don't think it's a conditioning. It must be a priming, because same clue but different kinds of a response depending on how they are primed to tell something. That's conditioning basically. I mean that's priming basically. And digit span and subtraction. Naveen is asking one more question, that is digit span and serial subtraction is immediate or short-term memory. And I've told you many times in my, usually in last year, I've told many times this, but I didn't explain this time. But actually this kind of digit span is an immediate memory. Digit span is an immediate memory. I mean, you're going to test for sensory memory for that. For example, if I tell a number 8754563513, don't rewind, just tell whatever I told you. Anyone can type? Nobody's answering. Okay. A lot of different answers. Okay, leave it. So I said, no, not one more time. I said 8754565313. So that is what the number I told. Probably I think so. Maybe it might be wrong. But why you're not able to tell? Because again, I mean, many people have been able to pick up to 5-6 letters almost. Many people have picked up 5-6 in fact. So that is the beauty of the digit span. So you have something called a forward digit span. And you have something called a backward digit span, which means from forward, how much you are able to tell is basically around 5 plus or minus 2. This is 7 plus or minus 2. This is a number of digits that you can remember and you can tell in the forward direction. It's a form of immediate memory. Suddenly I asked you. If I ask the same number after 20 minutes or half an hour, you will not be able to tell that. See, if you're able to tell after 20 minutes or half an hour, it's a short-term memory, which means you have paid a great attention to it. Since you have not paid sufficient attention, it just comes and goes like that. So the number that you can remember is 7 plus or minus 2 in the forward direction and 5 plus or minus 2 in the backward direction. So this is the basic digit span entity, but you know very well, you can now, if you think carefully, it's basically a test of immediate memory only. And of course, there is something called serial sevens. For example, 100 minus 7 is equal to 93. 93 minus 7 is equal to 86. 86 minus 7 is equal to 79. 79 minus 7 is equal to 72. 72 minus 7 is equal to 65. This is called a serial 7, where we keep on subtracting 7, 7, 7, 7. Remember, this is not a test of memory at all. First of all, here we are testing the ability to calculate. Calculation is completely done by a different area. That's a parietal lobe, Jesman gyrus, dominant side. So that is where you're getting the calculation. So this is the basis of calculation. So you think when I'm writing 100 minus 7 equal to 93, you think I remember that and tell? I mean, you really feel that I remember that and tell, like 100 minus 7 is equal to 93? Like you think my brain knows that 100 minus 7 is equal to 93. So I'm remembering that statement in my brain and I'm writing. No, that's not a memory, of course. So that is a calculation ability. That's a different kind of ability that I've been gifted with. That's calculation. That's a completely different thing. So for example, if somebody asks you 1400 multiplied by 100, even if I feel it's a good number, I know it is 140000. This is going to be the answer. And this is my calculation ability. I don't remember this basically. So I can do infinite calculations like this. If I know the proper steps, I can do even infinite calculations. But I cannot remember infinite things in my memory. So that's not even a test of memory. That's basically a test of calculation ability. So you should not confuse calculation with memory. That's another cognitive domain. I'm not disagreeing that it's the fact that it's not a cognitive domain. That's also a cognitive domain. But it's more often a test of calculation rather than a test of memory. So now you will be understanding about what do you mean by immediate memory, what do you mean by short-term memory, and what do you mean by long-term memory. I thought serial 7 was a technique to distract the patient's attention to the next question. Remember the 3 things I asked you before. Sony is telling that. Yes, actually he's asking about MMSE scoring. In MMSE, we have the serial 7, then we have this thing. No, it is not a test of distraction or attention. It is basically we are calculating. So why do, I mean, then what is the test of calculation then if you ask a serial 7? And why you, if you want to really distract the patient, then why you are giving a, like a score for that? So if it's really you're thinking about distraction, there are many distracting ways are there to distract the patient. You can show a video, you can show a Sunny Leone photo also for some time if it's a male patient. So why you want to distract only with serial 7s? I don't think serial 7 is a reason, it's a technique of distracting the patient. No, it's just that you're going to look for the calculation ability. If the patient is visually impaired, it's a very good question, isn't it? If a patient is visually impaired or if the patient is having a hearing defect, what about short-term memory then? So, as I told you, these are the 2 most important forms of short-term memory, iconic memory and echoic memory. But if you talk about other patients who are having visual impairment or hearing defect from birth, their other abilities will be strengthened. That is called cortical plasticity. We know that if one area is not functioning properly, that area will be covered up by another performance. For example, these patients may be very, sensitive in the smell, taste, and the touch and all these things. That also is a form of iconic memory only. This form of sensory memory only. For example, for me, this touching is, I don't think it's a form of sensory memory, but it's still a sensory memory, but I don't give that much importance to, because I'm giving more importance to what I see and what I hear. But these people might be giving more importance to what they smell. For them, it is like their iconic and echoic memory. So that is a different entity. That's completely a cortical plasticity. So where one area will overlap with another area and that area will get expanded, because that is the need of the hour for them to survive in this world. So that's different. So we don't want to discuss about that. So anyway, sensory memory in the sense, whatever it is immediate, I'm going to call it as a sensory memory for that matters. So the basic 2 types of sensory memory is iconic and echoic memory, which is going to be effective. And many, that comes to a conclusion. Many students do ask me like, how do you do a long-term memory? Remember, long-term memory is possible only in one possible way. One is going to be the emotions. Either you have to associate yourself with emotions, probably, I don't know how to tell about that. Maybe if some patient dies because of your bad treatment, and definitely you will not forget that, because that's a bad emotion associated with that. So that's one of the way, but that's too late. But if you want to really know for exams, the only way is to go for repetitive behavior. So repetitions, that's the only way. That's the basis of our, talking about revisions multiple times. But remember, again, revisions in the sense we are still in the superficial area only. But many students still again falsely misconceive by the fact that revision means you are pushing into long-term memory. We are talking about repetition, not revision. Repetition means the same thing you are doing again and again. That is repetition. But revision in the sense you only touch the subject superficially. That's a revision. There's a lot of differences between revision and repetition. For example, if you do a bariatric surgery, after doing a bariatric surgery, you do something called a revision surgery. What do you mean by revision surgery? You don't do the exact surgery. You just revise certain some openings, you just connect it in different area. So this is a revision surgery. So revision is not the same as repetition. So I don't know how to tell because there is considerable confusion among the students. Repetition means you should study everything from the beginning. So that is repetition, but it's not revision. And there is something called a memory curve. So, and who invented this memory curve? Have you heard about something called Ebbinghaus? Yes, Amia told the right answer, that is revised edition of a book. There is something called Ebbinghaus memory curve. So where he found out that over a period of time, the memory gets coming down exponentially like this. So what he did is, he wanted to revise some random things so that he wants to keep the memory intact like this over a long period of time. But even in Ebbinghaus memory curve, it's been clearly proven that whatever, even if you're doing multiple revisions and try to prevent the losing of information over a period of time, they're actually trying to show the short-term memory only. It's short acting. It's a short-term memory only. It's not a form of long-term memory. So to produce a long-term memory, the only way is either you have to repeat the same thing again and again multiple times, or you have to associate them with a lot of emotions, or you have to do procedures which has a direct ticket to the long-term memory. Apart from these three, it's not possible to push into long-term memory. First of all, especially for a PG preparation, yes, recall is different. As far as a PG preparation is concerned, you are actually trying to store everything in the short-term memory only, because you are neither repeating nor associating with emotions, nor you are doing any procedures. So that's why if somebody tells you during your PG postgraduate preparation you are associating with long-term memory, means that's absolutely wrong. So you can ask many of the postgraduates of your seniors itself. You can ask whatever they studied during the PG preparation, they cannot be able to recall even 10 or 5%. I mean, they can be able to recall whatever they read in, for example, a surgery assistant, if you ask, they will tell what all they read in surgery, because that's a direct association, but they'll not be able to tell what they have read in medicine, unless until it is strongly associated with certain emission. They've repeated that so many times. It's impossible. Again, it follows the Ebbinghaus memory loss curve only, because once again, you are associating it with the short-term memory. You are not basically associating with the long-term memory for that perspective. So that's really, really important. Again, recall is of two types. I mean, many different types of recall are there. One is your immediate recall is there. So that is a fine. I mean, if Saurabh is asking what is recall. Recall is immediate recall. The digit span is the best example of an immediate recall. Then you have a short-term recall is there. As I asked you morning what food you had. That's an example of a short-term recall. Long-term recall means it's a sign of a long-term memory. For example, if I am a cricket player, if you ask when India won the World Cup last, it's a cakewalk for me. I'll tell 2011. Before that, when the last World Cup was won, in 1983. I know that. I can tell a lot of details with regards to that. Kapil Dev, who are the players, 11 list of players. I can tell which ground, what score, which turned the match. The Kapil Dev's catch of Vivian Richards turned the match, and last wicket how it fell. It's bold. Everything I can tell from lots, like Balgani, who are all there at that point of time. How the trophy was received. Kapil Dev received in right hand or left hand. Everything I can tell. That's because something a part of mine. So that created a lot of inspiration for me. So you have a long-term recall, short-term recall, and you have a immediate recall also. That's why whenever you're testing for a long-term memory in clinical practice, it should be based on the patient. It should be changing from patient to patient. You should ask the interest of the patient. For example, if this kind of memory is long-term memory, if I am going to ask someone else who's not even interested in cricket, they'll tell what's the question you're asking, man. That's what they will tell. For example, if it's a soccer fan, I will be asking more of Arsenal and Manchester United, and I'm going to ask those kind of questions. So that's fine. So I can ask about Ronaldinho's, like the first goal in the World Cup from 40 feet against England. So I can ask this kind of information from a soccer fan. So it all depends. So on who you're testing, and you have to change that from person to person. So what kind of information you're going to ask. So this is a kind of a long-term memory. And we have different forms of memory. I think it's enough about memory, and we know about the Ebbinghaus memory loss curve also. And most of the time it will be associated with the short-term memory only. Long-term memory means it will not usually be lost. I mean, according to our, like understanding, long-term memory is something like a long-term. Of course, you should not lose, and the Ebbinghaus curve will be applicable only for a short-term memory only. And that is the reason why revision is just to maintain the memory in the floating area, which means you don't lose information. That is the reason why you do revision. But repetition is the one that is going to push the memory into a long-term memory. And of course, in the PG preparation period, you cannot really push the memory into a long-term memory unless and until you do it on your own hand, something like a procedure. So it's not possible otherwise. So that's the basic difference. And it might be a bad news for many of you, but still everyone goes through that phase. It's not only you who's going to go through that phase, but nevertheless, hopefully you understand this. Let us move to the major neurocognitive disorders. And as far as the major neurocognitive disorders are concerned, the first thing we are going to talk about is the Alzheimer's disease. We know what are the, like different pathologies that are associated with Alzheimer's disease. I'll tell you, Alzheimer's is the most common neurocognitive disorder in the world. In the fact, like most common primary neurocognitive disorder, which means you don't have any background cause for Alzheimer's disease. Most common primary neurocognitive disorder in the world. Since previously it was called as dementia, I can tell most common dementia in the world is Alzheimer's disease only. Then we have certain genes that can be associated with Alzheimer's disease. So what are the genes that are associated with Alzheimer's disease, basically? Anyone can tell? What are the genes? Not AB40 is not a gene. Yes, presenilin 1 is a gene, and we have presenilin 2 also. Not A beta 40. A beta 42 is also not a gene. We have a lot of genes. So as far as the Alzheimer's disease is concerned, so I can divide into two things. One is certain genetic factors and pathophysiological factors that are associated with Alzheimer's disease. As far as genetic factors are concerned, we have three major genes. Three genes that are major, that is associated with early Alzheimer's disease, early in the sense like 60s, 70s. Alzheimer's disease generally happens after 80s and 90s, but like around 60s if you get Alzheimer's disease, so that's sign of an early Alzheimer's disease. Usually you don't really get early Alzheimer's disease unless until you have a strong problem with your APP protein like Down syndrome. You get Alzheimer's disease around 40 itself. But apart from that, usually Alzheimer's disease will be happening around 60, 65, at least after 65. Even if you get around 60, 65, I'll be called as an early Alzheimer's disease. There are three genes that are associated with a little early Alzheimer's disease. One is going to be the presenilin 1, of course. And we have presenilin 2. And the third one, we have something called a APP, that is amyloid precursor protein. And remember the fact that presenilin 1 is present in chromosome number 14, and presenilin 2 is present in chromosome number 1, and APP is present in chromosome number 21. Remember, this APP is the one that's going to serve as a precursor for the production of A beta amyloid. This APP is going to serve as a precursor for the formation of A beta amyloid. And this is the basic pathophysiology of development of Alzheimer's disease as far as we know right now. So that is the reason why whenever APP is produced in excess, you will get more A beta amyloid, you get Alzheimer's disease very fast. So the best example for that is Down syndrome. So what do you get in Down syndrome? In Down syndrome, you have trisomy 21 because you have three genes now that produces the amyloid precursor protein. Because more and more APP you produce, more and more A beta amyloid are going to generate, the faster Alzheimer's disease you get. That's why Down syndrome's patients develop Alzheimer's disease by 40s itself. Apart from that, even other gene mutations are going to result in Alzheimer's disease by 60s only, but a little early compared to the sporadic Alzheimer's disease. And one gene is there that increases the risk of development of Alzheimer's disease. That is ApoE gene, that is present in chromosome number 19 basically. That's an ApoE gene. As far as ApoE gene is concerned, you have many polymorphisms are there for ApoE. You have ApoE2, you have ApoE3, and you have ApoE4. Remember the fact that ApoE4 is going to increase the risk. This ApoE4 polymorphism, ApoE4 allele is going to increase the risk of development of Alzheimer's. whereas ApoE2 is basically protective for Alzheimer's, and ApoE3 is supposed to be neutral for development of Alzheimer's, which means it doesn't increase or decrease the risk, but ApoE4 increase risk, whereas ApoE2 is actually protective. It decreases the risk of developing Alzheimer's in the long run. So now 4 things I've told you. One is presenilin 1, presenilin 2, APP, and ApoE, especially the E4. So these are things that increase the risk. But as far as the strong genetic association is concerned, you need to tell these 3 things only. Presenilin 1, presenilin 2, and APP. That is amyloid precursor protein. That's what you call APP. As far as the pathophysiology is concerned, pathophysiology is quite simple. It's going to be the formation of A-beta amyloid. A-beta amyloid is going to be the most important. And to know how A-beta amyloid is formed, let us talk about the theories behind it. So first of all, you have 2 types of secretases. One is called alpha and beta secretase, and the second form of secretase is beta and gamma secretase. In that, alpha and beta is going to be a little okay, and beta gamma is going not to be okay. So these different type of secretases that cleave this amyloid precursor protein is going to be the primary problem here. So first, let us talk about the A-beta amyloid formation. So you have the APP gene, which is going to produce the APP protein, and this APP protein is basically cleaved by 2 kinds of secretases. Normally, at a baseline level, this will be cleaved by something called alpha and gamma kind of a secretase. These are 2 secretases that are going to cleave the amyloid precursor protein at a normal baseline setting. And as far as the Alzheimer's disease patients are concerned, this APP protein will be more cleaved by the beta and gamma secretases. This beta and gamma secretases are the ones that are going to result in the formation of A-beta amyloid from amyloid precursor protein, not the alpha and gamma secretases. So these are the ones that are going to form A-beta amyloid. There are a lot of risk factors that increase the functioning of the beta and gamma secretases. Like for example, this presenilin mutation sometimes can be associated with increased activity of beta and gamma secretases, or probably excess production of amyloid precursor protein, which means this alpha gamma secretases will be overloaded and they will be saturated, and then there is no other way, they have to come to the beta gamma secretases. So nevertheless, the beta gamma secretase activity is the one that is going to result in A-beta amyloid. And we have basically 2 types of A-beta amyloid. One is called A-beta 42 and second is called A-beta 40. In that, we also know already, we have studied this, A-beta 42 is the one that is pathognomonic for Alzheimer's disease, not the A-beta 40. This is going to result in Alzheimer's disease, but this is not going to result in Alzheimer's disease. But remember, both can result in something called a cerebral amyloid angiopathy. I told you. CA can be produced by both, but Alzheimer's disease is typically produced by this A-beta 42 amyloid only. Clear? So I told you the important point regarding that. That's the reason why Alzheimer's disease invariably will be having some amount of cerebral amyloid angiopathy, but all patients with cerebral amyloid angiopathy may or may not have Alzheimer's disease. Doesn't matter. Okay, fine. So this A-beta amyloid, once this A-beta amyloid is formed, and we know the name amyloid is there, the moment you call the word amyloid is always extracellular only, with the exception of few amyloids which can be intracellular, but amyloid is always extracellular. So this A-beta amyloids, they're going to form some plaques, and if they ask you where these plaques are formed, these are basically extracellular plaques, and they will be extracellular. Amyloid means it's extracellular only. So these plaques create a sort of stress in the neurons, and if you ask how these plaques will look eosinophilic in H&D staining. They'll be looking like this, little rounded eosinophilic plaques, and this is what you're going to see in this stuff. This is A-beta amyloid plaques. This A-beta amyloid plaques are going to create a sort of a stress in the neurons. Maybe I can write something like this, which are extracellular, are going to create a sort of stress in the neurons. So this neuronal stress will result in activation of certain kinases within the neurons that will result in hyperphosphorylation of certain protein, for example, like tau proteins. So I can write the background microtubules. Let us assume these are going to be the microtubules. And these microtubules are basically united by certain proteins called tau proteins. And because of the stress that is induced by our A-beta amyloid plaques, they're going to activate a variety of kinases that results in hyperphosphorylation of tau proteins by an unknown mechanism. And this hyperphosphorylation of tau proteins will result in, like detachment of the tau proteins from the microtubules. And once the microtubules and the tau proteins are detached, because microtubules are the ones that form the basic structure of the cell and integrity of the cell, you need microtubules, and the cell will collapse at a point of time. And these disintegrated and hyperphosphorylated tau proteins can be seen within the cell intracellularly, and this hyperphosphorylated tau proteins is what we refer to as something called a NFT, that is neurofibrillary tangles. So NFTs are nothing but hyperphosphorylated tau protein accumulations within the cell, not intranuclear, it is intracytoplasmic, intracellular, but they are intracytoplasmic inclusion bodies. So hyperphosphorylated tau proteins. And basically, Alzheimer's disease is also a type of tauopathy. You can understand, isn't it? Alzheimer's disease is also a type of a tauopathy only, which means there are a variety of other disorders that can result in the accumulation of tau proteins within the cell, which I'll be substantiating later on. But Alzheimer's disease, you can, as you understand now, it's a type of a tauopathy only. Clear? Because it's due to accumulation of tau proteins. But remember, these hyperphosphorylated tau proteins that happen in the Alzheimer's disease should be called as NFTs, neurofibrillary tangles. Usually, if you ask the shape of the neurofibrillary tangles, they will be like flame shaped most of the times. If you see the textbooks in pathology books, they'll be more flame shaped, more basophilic, and they'll be typically inside the neuron, intracellular, intracytoplasmic. So this is how your neurofibrillary tangles are going to look like. As far as amyloid is concerned, these A-beta amyloid plaques are there. As far as I told you, there are two pathophysiologies now. One is the A-beta amyloid plaques. This is extremely specific for Alzheimer's disease, which means it's not seen in any other disease, any other NCD apart from Alzheimer's disease. When you take the neurocognitive disorders, these A-beta amyloid plaques are exclusive for Alzheimer's disease only. It's not seen anywhere else. And as far as the A-beta amyloid plaques are concerned, they are not specific for severity, which means they are not proportional to severity. So they are specific for Alzheimer's disease, but does not correlate with severity. So I can tell in a different way. Does not correlate with severity of the disease, but they're very specific for Alzheimer's disease. They're not seen in any other condition. But as far as the second thing is concerned, we have the neurofibrillary tangles, NFTs. As far as neurofibrillary tangles is concerned, they are not specific for Alzheimer's disease. Why? Because they can be seen in other tauopathies. For example, your Pick's disease, frontotemporal dementia, is also a type of a tauopathy only. I mean, there are many other tauopathies out there, so it's not specific for Alzheimer's, but which means it's a tauopathy. These tau inclusion bodies are not specific for Alzheimer's. At the same time, these neurofibrillary tangles do correlate with severity. The amount of NFTs do correlate with severity of the disease. So that's the second point that you need to know about neurofibrillary tangles. And if they ask you the first area to be affected in Alzheimer's disease, of course, it's going to be the medial part of the temporal cortex. The medial temporal cortex is the first area to be affected in Alzheimer's disease. And of course, in the medial temporal cortex, if they ask you what is the first area to be damaged, that is going to be the entorhinal cortex, then followed by hippocampus. Both these areas are very important for short-term memory. Both entorhinal cortex as well as hippocampus, both are very important for short-term memory. But the first area basically damaged in your Alzheimer's disease is going to be the entorhinal cortex. That's going to be the most important. So both areas are important for short-term memory. So clinically speaking, the first thing to be having a problem in the setting of Alzheimer's disease is going to be the short-term memory only. So which means they'll be having so much of inability to form new memories. In the sense, anterograde amnesia is a very typical finding in these disorders, in Alzheimer's dementia, where they will not be able to form new memories. Like, for example, I had an old professor, who I don't want to tell his name. He's from Madras Medical College, retired head. Now he's no more. And I used to work with him as a junior during my initial stages of post-graduation. I used to sit in his OPD in the evening times whenever I'm free. So he used to call me for help and all. So that time, he used to have 2-3 assistants and used to ask a coffee, he drinks a coffee. And he will give the cup, they will wash and keep also. After 30-40 minutes, he will ask again, like, I asked for coffee, where did you give me the coffee? And he will start scolding. I've asked so many times, I've asked, and you have not given me coffee. And what can we say? That's a typical example of a short-term memory problem. So immediate memory is okay. He knows he's drinking a coffee, but short-term memory cannot be created. And you cannot form any long-term memory if you cannot create a short-term memory. So this is what we call as anterograde amnesia. So the first thing that gets damaged in Alzheimer's disease is the short-term memory loss. So they will not be able to form new memories. Anterograde amnesia is the earliest finding. Inability to form new memories. That's a typical of Alzheimer's disease. And Alzheimer's disease, one important clinical feature is the fact that they'll be extremely slow in their progression. It means it takes years to progress. It will not progress very fast. In fact, it can take decades of progression. Slowly it will progress. And this is one of the very key feature for diagnosis in clinical practice as well as in exam, that slow progression. Whenever it's progressing very rapidly, that's unlikely to be Alzheimer's disease. You have to think about differential diagnosis for rapidly progressing dementia. For example, a Creutzfeldt-Jakob disease. All right. So I think this must be clear. So what do you mean by tau protein inclusions, neurofibrillary tangles, and what do you mean by this kind of like A-beta amyloid, and what is their importance? Do you understand? Do you understand or not? Shall we move on to the clinical features? Yes, thank you. Thank you for confirmation. So typically, Alzheimer's disease presentation will be amnestic, as I told you. So let us see the typical and atypical presentations. If you take the clinical features, I can divide into typical and atypical presentations. Typical presentation will be amnestic presentation only. That's a characteristic presentation from amnesia. Usually this amnesia will be anterograde amnesia. We know that in early stages. Later only they will become retrograde, anterograde amnesia. So later on they'll become retrograde amnesia. Then from this type of anterograde amnesia, then they'll go for other cognitive domains. Other domains will start getting affected over a period of time. So in the sense, they will be having visuospatial skill defect. Then they'll be having this kind of executive skills and speech, language. Slowly it will start getting affected. But the most important is going to be the amnesia at early stages. If you talk about atypical presentations of Alzheimer's disease, these are called as non-amnestic presentation, which means at presentation, they'll be having more of other domains involvement. Other domains will be involved at the beginning itself. That's an atypical Alzheimer, but very common is getting a typical Alzheimer only, where they typically present with this kind of amnestic presentation. So usually there are 4 stages of Alzheimer. One is A, B, C, D. A stands for amnesia, the first usual thing, and second they go for behavioral problem. That's a behavioral stage of the disease. And third is cognitive decline, and fourth is disability. Complete disability, bedridden stage. This is the 4th stage. This is a ABCD of Alzheimer's disease. So you have 4 different stages: amnestic, behavioral, cognitive, and disability stage. Amnestic is usually the first. Behavioral means they'll have behavioral issues like mood disorders, emotional problems, lability, psychiatric issues can happen, and they can have cognitive dysfunction like in the late stages like aphasia, agnosia, apraxia, and all this stuff. And disability means complete bedridden stage. That is at the late stage. So they can be completely bedridden, disabled. And remember, the motor neurons and all will be affected extremely late, at the final stage only, when the patient is completely disabled. And if they ask you the most common cause of death in these individuals, it's due to secondary infections only. That's the usual reason for death. Very common reason for getting a secondary infection is aspiration in the bedridden state, which means the disease itself does not kill you, but disease kills you by a different process. It makes you bedridden, and the falls will be more, injuries will be more, and the head injuries happen at a relatively higher incidence. And even cerebral amyloid angiopathy can cause intracranial bleeding, isn't it? Intracerebral bleeding in these patients, lobar kind of a bleed, and that could be the cause of death. So as of the cause, many reasons are there, but usual reason is secondary infection. That is aspiration pneumonia is a very common entity. that causes death in these individuals. So now we know. So what do you mean by Alzheimer's? Typical amnestic presentation. Early is anterograde memory loss, inability to form memories. That's characteristic. Or they can have atypical presentations, non-amnestic presentations like language disturbances and visuospatial dysfunction, executive dysfunction, aphasia. They can also come, but usually that's late in a typical disease. But atypical presentations are also not uncommon in our setting. And slowly they'll go for other memory loss also, remote memory loss, like they can go for that explicit memory loss typically. So they can have in the late stages. What about the remote memory? So I'll tell you an example. So there was one guy who was 82 years of age. So 82 years of age in the sense like his wife used to complain that he's beating me often and he's not listening to me. Whenever I tell something, you go out, you're not my wife. It looked as if like a psychiatric disorder. Then we started examining and asking him questions, what happened. But what really happened is it's an extreme late stage. He's been known Alzheimer's disease for 14 years. And he's actually explaining to us, telling that my wife doesn't look like this. She looks like something else. And I was like very shocked, like how come, like you might not. I was thinking about some kind of deletion of double, isn't it? That kind of a Capgras syndrome kind of a thing. But when you ask him, he was very clearly telling, but my wife doesn't look like this. She's looking very old. That's what she's telling. I was like, so then describe how your wife looked. My wife is very young, actually, basically. She's only 29 years of age, but she's old lady and she's telling she's my wife. What this bugger has done is he has lost all his retrograde memories and he's actually imagining that his wife, how she was used to be at 29, 35 years of age. And where can I go to bring that kind of a wife now? So he's telling that this is not my wife and get lost. And I'll not believe that you're my wife. So we thought initially it could be a Capgras syndrome, but actually it's not a Capgras syndrome. It's like a severe form of retrograde amnesia over a period of time. So that's one case history that I had. Then many behavioral problems we had. And the second case history is like when I had an intern in front of me who was sitting in front of me and practicing. There is a case who came. He came very normally inside. He didn't have any problem at all. He's well dressed, neatly tied, no problem. And but his actually family is complaining that he doesn't remember at all. Like whatever he does, he's not remembering. For example, he doesn't know what he had in the morning. Then later on, we found out he couldn't even get what he tries to tell. In the sense like he couldn't tell what he had in the breakfast also. Such a severe short-term memory, but he's very well dressed. So which means that's why I told you that importance of that early cognitive dysfunction. So patients who are having only mild cognitive dysfunction, in the sense that activities of day-to-day life may be normal. So that's why we categorize like that. So Alzheimer's disease patients are extremely notorious to come in that way, where they might have substantial defects in cognitive areas, but they will still be able to make up with other domains, and to some extent they could be able to make up and they can maintain their normal day-to-day living. So that will come under this mild cognitive dysfunction only, and Alzheimer's disease is going to be extremely important in that setting. They can fool you like anything. Just by seeing the dress and just by the way they converse, you should not think. And at the same time, I told you in a very typical and a common presentation, the other domain dysfunction will happen very late only amnesia will be there. And one example of that is, I asked, where are you working? Sometimes, or something, like this kind of a question you can ask. Like maybe one case history I will tell you. I asked what is 98 minus 25? So this is the number, for example, you're giving to a patient. These are very clever fellows. For example, especially this bank staff and all these fellows are very clever. They know that they're having difficulty in this. They will not be able to do that. But they will be talking like, doctor, why are you asking this? Don't you know this? You think I don't know? I know this. Even you know this. Why you want to give us such a simple calculation? As if they know to calculate it. Actually, they don't know. That's the problem. But they easily hide it by telling these kind of sentences, which means you should have a comprehensive assessment of all the domains in cognitive dysfunction. It's not only about one domain. So how cleverly they are answering. You'll sometimes even get fooled that, he's telling something and I'm asking, I'm embarrassing him. So it looks like that as, but you should never give up. In these kind of fellows, they might try to converse very logically and they might appear more logic and friendly, and they will try to hide their, dysfunction most of the time. So I've seen a lot of these kind of patients as well. So it's a little tricky scenario, but they may look, that's why that things are very important. Mostly they will have amnesia only. And, like slowly they'll go for dysfunction of other domains also. And even one more patient have I asked, like what work you're doing. Doctor, now only we have entered outside. You know what work I'm doing. So can't you know what work I'm doing right now? Simple. So these kind of answers only they are going to give. And Abram is asking, what will you do in that case? I mean, you don't leave them till you, what is there? You don't leave them till you tell the answer. That's all. So don't leave them. So tell, I know it, but still I wanted to listen from you. That's all. I mean, they can't escape in that. Okay. Some examples of Alzheimer's disease, and they can have a lot of behavioral issues. Behavioral in the sense like a lot of psychiatric problems they can get over time. That's very common in many non-neurocognitive dysfunctions. That's why psychiatry and dementias are always interlinked with each other. It's not, both are not different, because the cortex is going for a toss. You're going to result in a lot of psychiatric issues also. Like for example, they can have a Capgras syndrome. You know what is Capgras syndrome? That's a delusion of doubles. It was studied in psychiatry, where they will always think, like there is, that person who they are seeing is not the original person, and it's a kind of a double. It's a duplicate that they are standing in front of them. So that's called Capgras. And you have a Fregoli syndrome. You know what is Fregoli syndrome? It's like a constant kind of a stranger, and they can have a delusion of persecution. You can have a kind of a delusion of persecution. Then you have something called a phantom, stranger or phantom order. For example, they will always feel that, not phantom order, phantom border. In the sense, they will always have a feeling that, Fregoli is like a familiarity with a stranger. For example, a new person will come and you will have a kind of a familiarity, like the person will behave as if they are so familiar with them. So that's a Fregoli syndrome. Capgras is delusion of double. They're thinking that somebody has doubling, and it's a duplicate, and that is trying to cheat them. And persecution, somebody, they are having constant delusion that somebody is going to kill me, or somebody is going to do bad for me, harming me. And this kind of persecution of delusion can happen even when you are severely depressed also. Like when you are severely depressed, you will think everyone is trying to harm you. Everyone is trying to do something wrong. So that's, again, I'm not trying to confuse all these things. Anyways, phantom border. What do you mean by a phantom border? Like they'll have a constant feeling that there is someone that is in their home or whatever living place they are in. It's like, for example, Conjuring movies. You think like there's many stages they will tell in that kind of, like possessing a particular soul. So that, yes. So they will think like somebody is always there in the home. So that's what they do. Devils think like that. Devils make you think like that. So these patients will think there is always somebody there in the home, but they're not able to see them. So that's what we call it as a delusion of a phantom border. And they can go for wandering. Wandering is basically not a psychiatric problem, but a very classic symptom of Alzheimer's disease, especially in the moderate to late stages, where they wanted to go out. They go out and they don't lock the door also, because they forget to lock the door. And once they go out, they forget where they wanted to go. And after going out, they forget the way to come back to home also. So that will result in a stage of wandering in the streets. So some relative will see them and bring them back to the home. That's a kind of a scenario that you'll encounter. And they can go for depression, but that's very, very late. Depression, aggression, very late. But these are very rare phenomenon. And because why they don't get depression is because they don't have cognition to understand that they have depression. So that's very rare to have in Alzheimer's disease. They don't be depressed. They'll be very happy most of the times. Some patients may get depression, psychosis, agitation, aggression and all, but it's generally very rare to get this kind of a depression, because they don't really, know that what they're doing, because they forgot a lot of things. That's the reason. And that is also a difference between, that's also important to understand difference between a cortical and a subcortical dementia, or a cortical and subcortical neurocognitive disorder. Currently speaking, only cortical neurocognitive disorders, cortical problems only should be called as neurocognitive disorders. Subcortical problems will be something different, and we have a different terminology for that. It will not come under neurocognitive disorder. But nevertheless, the older classification of dementias is cortical dementia versus a subcortical dementia. In cortical dementia, amnesia will be a very early finding, and it will be a little late finding in subcortical dementia. And in the sense like other cognitive domains will be affected late, but here in subcortical dementia, it will be a little early. Other cognitive domains, like it could be dependent on visual or whatever it is. It will be early in the setting of a subcortical dementia. And motor problems. Motor problems will be very rare, and if it happens, it's late in setting of a cortical dementia. And in subcortical dementia, motor problems will be extremely early, like myoclonus, or probably this kind of Parkinson. You can think about tremors. So that will be very early in a subcortical dementia. On the other hand, yes, this depression and the psychiatric problems will be very common in cortical dementias. It will be very rare or late in the setting of a pure cortical dementia. Psychiatric problems. So some differences are there, but still I don't really think that these things really make any sense. It's a comprehensive assessment of them that's going to give you a diagnosis, and there's no point in differentiating cortical, subcortical, and you really don't have any reason to do that. You have to treat the patient ultimately. That's the most important. As far as investigations of this Alzheimer's disease patients are concerned, you are going to use certain investigations like maybe MRI and CT. Why CT and MRI? This is to rule out secondary causes, rule out other issues, and it's the most commonly requested investigation. But if some investigation that can diagnose Alzheimer's disease for sure is brain biopsy. But who's going to do a brain biopsy, cut open the skull to diagnose Alzheimer's disease? Yes, Alzheimer's disease is basically a clinical diagnosis, but you have some, like investigations like PET scan that are coming up right now. But nevertheless, Alzheimer's disease is still a clinical diagnosis. You have ruled out secondary causes. You have ruled out all the other possibilities. Then you have a neurocognitive dysfunction that is slower in progression. That's a very important word. That is slower in progression. In an elderly patient, you diagnose Alzheimer's disease. This is the exact way how to diagnose the Alzheimer's disease in clinical practice. Slow progression, neurocognitive dysfunction, predominant memory loss, typically anterograde amnesia, and very slow progression, as I told you, in an elderly, after you've ruled out all the other causes, it's Alzheimer's disease. It's a clinical diagnosis, basically. But if you want a gold standard, it's always a brain biopsy. There's nothing else that can diagnose Alzheimer's disease apart from brain biopsy for sure. But even though you can look at this A-beta amyloid plaques in certain PET scans, which I'll be telling you in some time. But nevertheless, what are the other investigations that you can do? You can do CSF analysis, unnecessary completely, where you can look for this A-beta amyloid levels in the CSF. I don't know which lab in India does. I generally don't do unnecessarily. And you can do SPECT imaging. SPECT, as I told you in cardiology itself, it's for assessing the perfusion to the brain. Because certain areas in the brain go for atrophy, and the first area to go for the brain is temporal lobe. And the second area of the brain to get atrophied is the parietal lobe in Alzheimer's. And the third area to go for atrophy is frontal lobe. And the final area to go for atrophy is the occipital lobe. So this is the way of, like damage as far as the Alzheimer's disease is concerned. So the temporal lobe and the parietal lobe are the usual lobes that show hypoperfusion in any stage of Alzheimer's disease, because their blood supply will be low because there will be cortical atrophy. And if they ask you A-beta amyloid plaques, first to accumulate, again it's in the temporal lobe, in the entorhinal cortex, then followed by the hippocampus. Temporal lobe is the first, especially the medial parts of the temporal lobes. That's going to the major pathologic area as far as Alzheimer's disease is concerned. Any disease that is not having, if you have some disease which is present in neurocognitive dysfunction, but you do not have that medial temporal lobe atrophy, or medial temporal lobes are spared and other areas are atrophied, it's not Alzheimer's disease. You're thinking about something else. Alzheimer's disease means that medial temporal lobe will be definitely atrophied. So SPECT, to an extent, you can predict Alzheimer's disease. Then you have PET scan also, where you can find out this A-beta amyloid plaques. This A-beta amyloid plaques are always also referred to as a neuretic plaque. Neuretic plaque. So this neuretic plaques can be identified. The A-beta amyloid plaques can be identified by certain PET scans. We have a compound. The tracer that is used in PET scan is the PAB. PAB is the tracer that we use. That's called the Pittsburgh compound B. Pittsburgh is an area, isn't it? We have something called the Pittsburgh compound B. So this is the tracer that we use to identify this, A-beta amyloid plaques. So using PET scan, you can find out the A-beta amyloid plaques, and in CSF also you can find out. And these are not important. Basically speaking, this is absolutely not important. And CSF can be done in certain places. For example, if I want to rule out certain meningitis and chronic infectious causes that can cause dementia, then I might be doing a CSF. But for the diagnosis of Alzheimer's disease, I don't think CSF is really needed. And CT MRI, very commonly you will be seeing a presentation, finding called as hydrocephalus ex vacuo. Hydrocephalus ex vacuo, that's the finding that you're going to see in the setting of imaging, radiological imaging. You know what you mean by hydrocephalus ex vacuo. Because of the cortical atrophy, patient will go for cortical atrophy. Because the cortex becomes smaller from all the directions, the ventricles become dilated. Of course, like when the cortex becomes small, there will be more room for the water to expand. So the ventricles will get dilated because of the cortical atrophy. And that's what we refer to as hydrocephalus ex vacuo. The vacuum that is created by the cortical atrophy is filled by the water in the ventricles. So that is a bigger ventricle-like appearance, hydrocephalus ex vacuo. Based on MRI appearance, based on ventricular size, MRI appearance of the brain, I can write, based on MRI appearance of the cortex and the size of the ventricles, and based on the opening pressure, CSF opening pressure. CSF opening means CSF opening pressure. I can give certain diagnosis which can be important in exam. Easily, whenever the cortex is looking okay, ventricles are dilated, CSF opening pressure is increased, this is a true hydrocephalus, or you can call it as an obstructive hydrocephalus. Whenever cortex is atrophied, ventricles are dilated, CSF opening pressure is normal. This is a typical situation of a ex vacuo condition. That's hydrocephalus ex vacuo, that is due to cortical atrophy. Your ventricles are appearing dilated relatively. And cortex is normal, ventricle is normal, CSF opening pressure alone increased. That's a situation where we have discussed all that's called IH, idiopathic intracranial hypertension, pseudotumor cerebri, where sometimes cortex may look normal, ventricles may be dilated, CSF opening pressure may be completely normal as well. So in this setting, you'll be diagnosing a NPH, that is a normal pressure hydrocephalus. Remember, again, you have to take with a pinch of salt. This normal and increased size of ventricle should be always relativistically taken, which means what we are trying is, relative means there could be some cortical atrophy, normal pressure hydrocephalus also, but this cortical atrophy should not produce that much dilatation of the ventricles. So it's always relativistic. There is index in radiology for how much cortical atrophy, how much ventricle should dilate. So if it's disproportionate increase in size of the ventricles with a normal opening pressure, that disorder is called a normal pressure hydrocephalus. So this table will be useful for your exams for sure, because many questions are going to come from that. Then how you treat Alzheimer's disease. Treatment is based on certain areas. Huntington's is a subcortical dementia. Huntington's is never a cortical dementia in the first place. Pranav is asking what happens in Huntington's. Huntington's is never a cortical dementia, it's a subcortical dementia. And MRI findings are absolutely non-specific, and you can see hyperintensity in the basal ganglia in MRI. That's a completely different presentation. You'll have a chorea, psychotic problems, and a family history. And as far as the treatment is concerned, it's based on one hypothesis, which we have not talked about that in the pathology. What that hypothesis, there is one area that will be damaged in Alzheimer's disease, that is nucleus basalis of Maynard. So nucleus basalis of Maynard, this area will be affected in Alzheimer's disease. So this is the area that generates acetylcholine. Because this area is damaged heavily, acetylcholine production will not be there in the brain, and that's a pharmacological theory for Alzheimer's disease. But even though we don't really know that's the only cause, that's effect of Alzheimer's disease or the cause of Alzheimer's disease, we don't know. But nevertheless, acetylcholine decline has been correlated with memory decline as well as our cognitive decline. So that is why we attempted to improve the acetylcholine levels in the brain by giving central acetylcholinesterase inhibitors. Remember, even though we call central acetylcholinesterase inhibitors, they do have some peripheral effects. So they can produce some cholinergic symptoms. Like bradycardia and all. That's why taking an ECG before giving these drugs is very, very important. So what are the central acetylcholinesterase inhibitors? We have drugs like donepezil, we have rivastigmine, and we have galantamine. And these drugs do not slow down the progression of the disease. Rather, it will only improve the memory. They cannot slow down the disease progression, but they can reduce the cognitive, increase the cognitive function to an extent, but progression will happen relentlessly no matter what. And at the same time, they do not prolong life expectancy. But only thing is they reduce the morbidity. They decrease the cognitive dysfunction or cognitive decline will be reduced. But there is no change in the mortality, which means they are not improving survival. At the same time, progression also will not be stopped. Only the cognitive function may be improved in Alzheimer's disease. So this is central acetylcholinesterase inhibitors, and even other drugs are there. NMDA receptor modulators. For example, we have a drug called as memantine. It's an NMDA receptor agonist basically. It's a modulator, and that drug is called memantine. We can use. So these are the drugs that are currently available. Okay with Alzheimer's disease, but like not very good anyways in treating the disease as such. And behavioral management is also very important in Alzheimer's disease. Like for example, we need to talk about certain neuroleptic drugs like haloperidol. So because many patients will be having severe psychosis, so we can use haloperidol to reduce the psychiatric symptoms. Or to reduce depression, sometimes you might be needing SSRIs. Many patients will be having disturbance in sleep. For that, you can give trazodone. This is for improving the sleep in this Alzheimer's disease patients. And you have Alzheimer's homes also, where in terminal stage you can push the patient to Alzheimer's homes. But nevertheless, it again depends. And once again, disease is not going to stop anyways. But we have some health societies and homes where you can push the old age patients there, if you are not able to take care of them. But they are very bad as far as India is concerned. However, the most important point with regards to Alzheimer's disease is its characteristic slow progression. That's going to be the most important point as far as any exam is concerned. So every exam clinically will be relying on this slow progression only. And that is the most important as far as Alzheimer's disease is concerned. I think you can go for a short break and come at 7:45 or 7:50 so that we'll continue with that. I think this is a tough topic, but I've tried to simplify as much as possible. Especially the memory and neurocognitive disorders are very, very tough. Hopefully it will be easy from now on. We go for a break and come. I think you can come back at 7:45.